Greetings to the second semester students. Today's topic of lecture is the mini mental status examination. So what is the MMSE? Also known as the Folstein test, it is a 30 points questionnaire which is used extensively in clinical and research settings to screen and measure the cognitive impairments in a patient. It's commonly used to screen dementia, and it is also used to estimate the severity and progression of cognitive impairment and to follow up the course of the cognitive changes that an individual can experience over time, thus making it an effective way to document an individual's response to the treatment. So, this scale is also used as a treatment protocol and also as a diagnosis protocol. So MMSE, I have written it in bold words. It's not the same as MSE, mental status examination, which is taken during the case history. This is only meant for measuring the cognitive impairments or the cognitive decline that a person experiences during the lifetime or period. So the administration of the MMSE, it takes between 5 to 10 minutes examining the functions including registration, attention, calculation. There will be some numbers given where you have to calculate, recalling. You would be given an address and the person's name to remember, and you would be asked at a later time. Language, ability to follow simple commands as well as orientation. It was originally introduced by Folstein et al. In 1975 in order to differentiate organic from functional psychiatric patients, but it is very similar to or even directly incorporates tests which were in previous use in its publication. The current standard MMSE form is published by the Psychological Assessment Resources. Advantages of the MMSE: because it is short and it is not long in comparison to the NIMHANS psychological battery, which can take up to several hours in a day and may not be possible to administer it in one setting. The MMSE requires a very short amount of time. It requires no specialized equipment or training for administration. It has validity and reliability for the diagnosis as well as the longitudinal assessment of Alzheimer's disease. But there are certain shortcomings. One is it's affected by demographic factors. Age, education could exert the greatest effect. The most frequently noted disadvantage of MMSE is the lack of sensitivity to the mild cognitive impairment and its failure to adequately discriminate patients with mild Alzheimer's from the normal patients. So, even if you get a score which is considered to be within the mild normal category, you would be considered as having a no cognitive impairment at all. But there could be patients requiring interventions in order to prevent further cognitive decline. But that gets missed out, according to this MMSE. MMSE also received criticism regarding its insensitivity to progressive changes occurring with severe Alzheimer's disease. And the content of MMSE is highly verbal, uh, lacking sufficient items to measure the visuospatial or constructional praxis. So it does not use the pen and paper mode. It's only verbal. So the client is not asked to draw or not asked to replicate any of the items that are being shown on a table by the clinician, but only MMSC is concerned with is it's highly verbal. It only records the verbal statements, no written statements. So its utility in detecting the impairments that is the visuospatial impairments or constructional praxis, could be really uncertain. Let's move on to understanding the features of the MMSC. The MMSC test includes simple questions in a number of areas. You can be asked the time and place of the test, repeating some list of words, arithmetic of serial sevens, so 7 plus 7 plus 7 or 7 minus 7 minus 7 minus, language use and comprehension, basic motor skills. So the version of MMSC questionnaire can be found on British Columbia Ministry of Health websites. And although consistent application of identical question increases reliability of comparisons used, the test can be customized. If you have a blind patient coming in for the screening, so you can customize it accordingly to the you can customize the wording of the questions according to the blind client or the deaf client. So the number of points that are assigned to each category is consistent. The orientation to the time, it's usually 5 total points. Orientation to place is 5. Registration 3, attention and calculation 5. Recall maximum points you can give is 3. Language 2, repetition 1, complex commands is 6. When you come to the interpretation, any score of 24 or more out of 30, it indicates a normal cognition or cognitive functionality. But if the client is getting a score of 24 below, the scores can indicate severe if it is less than 9, moderate, cognitive impairment if it is between 10 to 18, mild if it is between 19 to 23. So the raw score may need to be corrected for educational attainment and age. So when you're taking the case history of the client, make sure to not miss out on noting down what are the educational qualifications and the age, biological age of the client, so that even a maximum score of 30 points can never rule out dementia. Low to very low scores correlates closely with the presence of dementia, although other mental disorders can also lead to abnormal findings on MMSE. The presence of purely physical problems can lead to interference with interpretation if it is not noted properly. For instance, a person may be physically unable to hear or read instructions or have motor deficits that could affect the writing and the drawing skills. MMSE is known to differentiate among different types of dementias. However, systematic reviews of this test shows no evidence to support examination as a standalone one-time test for developing high-risk individuals who are likely to develop the Alzheimer's. So, coming to you have to correlate MMSE with more further screenings if the person has uh, been said to have cognitive impairments, then you need to go for further testing in order to rule out dementia and Alzheimer's. Now, according to Tomberg and McIntyre, how to use the MMSE better? It should serve as a screening device for cognitive impairment, diagnostic adjunct, in which a low score indicates the need for further evaluation. So it should not be only the sole criterion for diagnosing dementia. However, the scores can be used to classify the severity of the cognitive impairment or to document a serial change in dementia patients. The four cutoff levels should be employed to classify the severity of impairment. As I've mentioned, no cognitive, mild, moderate, severe, according to the numbers and the ranges. The MMSE should not be used clinically unless the person has a grade 8 education, where further clarification is required. That is why the case history is very much important and is fluent in English. So the person has to have a grade 8 education, is fluent in English. While this recommendation does not discount the possibility that future research may show, it does acknowledge the weight of evidence that low educational levels can increase the likelihood of misclassifying normal subjects as cognitively impaired. So please make sure to take proper demographic information of the client before proceeding on to the test to rule out these possibilities. Serial sevens and world should not be considered equivalent items. The words apple, penny, table should be used for registration and recall. If necessary, the word should be administered up to 3 times in order to obtain perfect registration, but the score is based on the first trial. The country and the where are you should be modified according to where you are administering the test. So if I'm administering the test, even if it is developed in US, I cannot, if I'm administering the test in India and it is developed in US, I cannot ask, so where do you stay? If the person says Jalandhar, then I cannot say it's wrong because we are India. So the person will say the local context. So you have to be mindful of this thing. There are many versions of the MMSC which has come up, and they are in 2010 the psychological assessment resources have published a second edition of the MMSC. It has been also translated into 10 foreign languages. So this is how efficient the MMSC is for the diagnosis, screening, and the treatment process. Thank you so much for patiently listening. I hope today's discussion was fruitful for you. Thank you and have a good day.